Dear students, today's our topic is acute pancreatitis. How to define it? Inflammation of pancreatic parenchyma leading to high circulating level of activated pancreatic enzymes in circulation, sometimes resulting in systemic inflammatory response syndrome and multi-organ dysfunction. Picture of acute pancreatitis is variable, mild oedematous and severe hemorrhagic necrotizing pancreatitis. Mortality 12% with treatment. Etiology and causes include the mnemonic is get smashed. G stand for gallstones 60%, E stand for ethanol 20 to 30%, T for trauma, S for steroids, M for mumps, A for autoimmune disease like PAN, SLE, S for Scorpio sting, H for hypercalcemia, hyperlipidemia, hyperthermia, E stand for post ERCP, D for drugs, nitrofurantoin, etc. Pathogenesis: infection of gallstone at ampulla of Vater. Cause number 1, bile regurgitation into pancreatic duct, which cause pancreatic which reach in pancreatic parenchyma and cause activation of pancreatic proenzymes within pancreas, which cause inflammation of pancreas. Number 2, enterokinase cause regurgitation into pancreatic duct, which reach pancreas to activate pancreatic proenzyme and cause inflammation of pancreas. Number 2, ethanol increase protein content in pancreatic juice, cause protein rich pancreatic juice formation, which cause mucus plug formation in pancreatic duct, which cause obstruction and stasis, which cause overgrowth of flora, which cause inflammation. Trauma or viruses cause direct injury to pancreatic acini, which cause release of pancreatic enzymes, which cause inflammation. Abdominal pain with tetany is acute pancreatitis until proven otherwise. Effects or outcome of acute pancreatitis: acute abdominal pain plus GIT, upsets, nausea, vomiting, diarrhea, etc. Complications include number 1, hypocalcemia, cause muscle twitching, cramps, carpopedal spasm, tetany. Reason: hypocalcemia cause increased lipase activated breakdown of lipids, cholesterol, TGs, LDL, VLDL into fatty acids. Fatty acids combine quickly with calcium and make calcium soaps, saponification, which cause hypocalcemia. Number 2, shock, SIRS, cause increase pulse, increase respiratory rate, decrease BP, increase temperature. Cause activated protease in the blood, cause damage to vessel wall, basement membrane, collagen, which cause third spacing due to pleural effusion, ascites, pericardial effusion, edema, which cause shock and which cause acute renal failure, ARF. Number 2, ARDS, acute respiratory distress syndrome. High protein content cause pulmonary edema, increased protease damage to pulmonary vasculature. Number 4, DIC. Increased protease cause widespread vessel wall injury, which cause consumptive coagulopathy. Late complication includes pseudocyst, collection of fluid between stomach and pancreas. Number 2, pancreatic abscess. Number 3, pancreatic fistula. Number 4, pancreatic necrosis. Number 5, chronic pancreatitis. Clinical features of acute pancreatitis include risk factors: pain, pain site is epigastric, nature sharp agonizing, intensity severe, radiation to back, aggravated by lying down because touch nerves, relieved by bending forward or by analgesics. GIT upsets, nausea, vomiting, tetany, cramps, twitches, carpopedial spasm. On general physical examination (GPE), increased pulse, increased respiratory rate, decreased BP, increased temperature due to SIRS, systemic inflammatory response syndrome, cyanosis, chest shows crepitations due to ARDS, stony dull percussion due to pleural effusion, abdomen inspection shows lying still, distended abdomen. In case of hemorrhagic pancreatitis, Cullen sign, bruising at the umbilicus, Gray-Turner sign, bruising of flanks, rashes at flanks. Palpation shows tenderness, epigastric, mild plus gardening. Pain is far more than tenderness because of peritoneal organ is pancreas. Percussion, fluid thrill positive, shifting dullness positive. Auscultation shows bowel sound plus minus. Investigation, first line screening test, serum amylase more than 1000 international unit, normal 30. It can be raised in any foregut pathology, esophagitis, peptic ulcer disease PUD, hepatitis, cholecystitis, parotitis. First line serum amylase more than 1000 international unit, normal 30. Specific serum lipase generally last longer but less sensitive. Complete blood count CBC shows raised TLC. RFT shows acute renal failure. Coagulation profile shows DIC. Chest X-ray shows ARDS, pleural effusion. ABGs show respiratory failure. BSL is raised. Serum calcium is low and serum albumin is low. Investigation of choice is CT abdomen. Prognosis is determined by modified Glasgow criteria. Mnemonic is pancreas again. P for partial O2 less than 8 kPa. Age more than 55 years. Neutrophils more than 15,000 per mcl. Calcium less than 2 millimole per liter. Renal function more than 16 millimole per liter. Serum urea. Enzymes AST and LDH raised. Albumin less than 3.2 gram per dl. Sugar more than 10 millimole per liter. Interpretation, more than 3 factors within 48 hours of onset, indication of ICU admission. Treatment include NPO nil per oral, IV fluids, IV antibiotics, ceftriaxone plus metronidazole, analgesics, IV NSAIDs. Avoid pethidine, gallstone contraction of ampulla of Vater. Monitor vitals, pulse, BP, temperature. Monitor electrolytes, ABGs, BSL, enzymes. If gallstone ERCP, indication for surgery, late complication. If patient is having late complication, then indication will be surgery. That's it about acute pancreatitis. Very important for exam point of view. Thank you.